Welcome to the Clinical Education Initiative podcast, Conversations with CEI, where we feature conversations with clinical experts, their experience and insights on current health issues in the areas of HIV, primary care and prevention, sexual health, hepatitis C, and drug user health.
Welcome to Conversations with CEI, a podcast featuring interviews with leading advocates and providers in the field of HIV. I'm Tony Urbina, the medical director for CEI's HIV Primary Care and Prevention Center of Excellence. As a provider and professor of medicine with over 20 years of experience in the field of HIV, I'm excited to bring you another insightful episode. Providers calling into our CEI hotline often ask me what to do when their patients' HIV test results are unclear. These ambiguous or discordant test results can be a source of anxiety and confusion for both patients and healthcare providers alike. To provide additional insight into this complex issue, I've invited a renowned expert in HIV testing to join us today. I'm thrilled to welcome Dr. Lucia Torian to our conversation. Dr. Torian is a distinguished epidemiologist who has dedicated over 3 decades of her career to the New York City Department of Health. As the Deputy Director of the HIV Epidemiology Program, she brings a wealth of expertise in HIV diagnostic testing and case surveillance. In our Q&A and discussion today, we'll dive into real-world scenarios that illustrate the challenges of interpreting HIV test results. We'll explore cases involving early exposure, false positives, and even the complexities that arise when working with migrant populations. Dr. Torian offers valuable insights on managing patient anxiety, effective communication strategies, and the future of HIV testing technology. I'm excited to share this conversation with you. So without further ado, let's jump into our discussion with Dr. Lucia Torian. Welcome, Lucia. Thank you for being here. I know you and I have had to handle a lot of these cases back and forth, and oftentimes it's not just resolved just with one phone call or one conversation. So it's great to have you on our podcast. So I'd like to start by us kind of delving into the topic of ambiguous and discordant HIV test results. We know that these can be a source of anxiety for both patients and providers. Can you walk us through some of the factors that might contribute to such results?
First, let's remind ourselves that an HIV diagnosis is never based on just one test, any more than you would base a diagnosis of diabetes or thyroid disease on just one test. So HIV diagnosis always involves a series of tests from screening to confirmation. It's a 2 or 3-step process. And we say that the test series is ambiguous or discordant when one of the test results doesn't agree with the other. One says positive, the other says negative or undetectable, or when the test results come back saying inconclusive or indeterminate. And that's what they're going to do when an antibody to only one of the HIV glycoproteins is present and it doesn't meet the definition of confirming an HIV diagnosis. So first you have to eliminate what I call the usual suspects and what labs call technical problems. You might submit one tube and hopefully it's the right tube with the right patient's name on it. And a lab will split it into 2 or 3 other tubes, what we call in the lab an aliquot. On arrival at the lab, the specimen might be old, it might be hemolyzed, it might be QNS. It might end up getting mislabeled on the 2nd and 3rd aliquot. And you have to know the lab will notice that if you're really lucky, and they'll tell you what was wrong, and they'll ask you for a redraw. And this alone is scary and frustrating for you and for the patient who's anxious to begin with, because it means more waiting. And convincing the patient that you need to repeat the test because you want it to be as accurate as possible is important, and we hope it's persuasive. In the meantime, you need to counsel the patient who's waiting for the second round of results to practice safe sex and safe injection. But once you've eliminated those specimen-related problems, the discordant scenario we most often see is a positive screening result combined with a negative confirmatory result. or inconclusive. In lab language, this would be a repeatedly reactive 4th or 5th gen screening test and a negative HIV antibody differentiation test. First, you want to rule out whether the positive screening test represents what we call non-specific reactivity. You're going to want to ask yourself, is the patient pregnant? Does the patient have a viral infection like flu or mono? Does the patient have an autoimmune disease like rheumatoid arthritis or lupus? Has the patient recently been vaccinated for flu, COVID, RSV, pneumococcus, and his immune system is activated? Did the patient recently receive immune globulin, like after exposure to meningitis? Did the patient ever participate in an HIV vaccine trial? That's the case where we might show antibody to only one of the structural glycoproteins of HIV. And finally, and this is by no means the exhaustive list, does the patient use injecting drugs? If any of these is the case, the patient might be exhibiting an anti-inflammatory response that includes non-specific reactivity, and you need to repeat the test. Be mindful that there is an occasional patient who routinely tests positive on screening and whose supplemental or confirmatory antibody tests and RNA tests repeatedly come back negative or undetectable. Sometimes this can go on for months, and it is a very tough situation, both for the doctor and the patient. Back to all these factors in the patient's history and current status, they can all cause reactivity on a screening test. However, if you're using a 5th-generation test that not only looks for antibodies, but also looks for P24 antigen, which is detectable by about day 12 and until day 40 after infection, and the test, like the Perplex assay, reports back to you the specific analyte, whether the reactivity was due to P24 antigen or antibody, and you've got a P24 positive, then you have a pretty good indication that the patient has HIV. If the confirmatory antibody differentiation test is negative, you have to rule out whether the patient has acute or very early HIV infection. During acute infection, the patient will have circulating virus but hasn't yet had enough time to make measurable anti-HIV antibody. When the lab sees this combination of test results, they should automatically reflex to a diagnostic nucleic acid test, in other words, a viral load, to resolve the diagnosis. But they may have used up the specimen, so there's nothing left of it, and they may not have aliquoted your specimen and have spun it down and saved themselves some plasma just in case this becomes a problem. Some labs don't, so they may ask you to bring the patient back for a redraw. The more difficult scenario that discordant and ambiguous test results present is when you're testing a patient on PrEP every 2 months to make sure that the patient hasn't become infected. What should you do to resolve the ambiguity? The literature suggests 2 approaches. Repeat the test a couple of days or a week later based on the possibility that the ambiguous tests were due to very early infection or technical problems like what we already talked about. In this case, while you're waiting, you should continue PrEP until you get the next round of test results. The pretest probability that an adherent patient is not infected is high. If infected, continuing PrEP affords at least some level of viral suppression while you wait for the new test results. It's important, however, to resolve the issue as soon as possible because PrEP offers inadequate antiretroviral therapy, and you'll want to get the patient started on fully suppressive ART as soon as the infection is confirmed. The second option that you have is to start ART. This might be the preferable choice for a patient that acknowledges not being fully adherent to their daily oral PrEP. This you do by adding a third ARV to their PrEP regimen, like dolutegravir or boosted darunavir. This allows you to act fast and minimize the possibility that the patient may develop resistance against Truvada. The full ART exposure can be discontinued as soon as you have confirmed negative test results, no harm will have been done, and the patient can continue on PrEP. A new thing to remember, since it may become increasingly important, is that long-acting injectable PrEP can suppress viral circulation enough that antibody will not be generated because the body's not stimulated to do it. And the test will be negative for months, even if the patient is infected and even after discontinuation of PrEP, because they don't call it long-acting cabotegravir for nothing. It's very long-acting. And this is a scenario that's rare, but it is increasingly being reported, as is the use of long-acting injectable cabotegravir. So I recommend that you stay tuned to your favorite network, CEI, for updates on this situation and how best to handle it. As Tony has mentioned, this period of uncertainty is going to be stressful for you and for the patient. And since you are managing their PrEP, you likely have a longstanding good relationship with them and a level of trust, and listening to them and sensitively acknowledging the anxiety associated with ambiguous test results might help you both through this waiting period. Counseling patients and saying, hang in there, can sound about as empty as the subway PA saying, thank you for your patience when you're furious because you can't make your next appointment on time. But convincing the patient that it is worth waiting because you want the test to be as accurate as available technology allows is important, and we hope it's persuasive. That sensitive talk means that you need to take some time with the patient and really listen to their feelings and their fears and assure them of the next steps you will take, whether the patient's negative or positive, as soon as the new tests are available.
Great. Lucia, thank you so much for that really clear and concise kind of overview of what ambiguous and discordance HIV test results. I kind of wanted to then maybe unpack a little bit just one of the scenarios of that first repeatedly reactive screen and then followed by negative antibodies and then negative PCR or viral load. You often talk about like tiebreaker test, but could you go over just the next steps that you would take? You're obviously going to counsel the patient, but what are the next steps and what are kind of the tiebreaker labs that you would recommend next?
The tiebreaker labs are the same labs that we do initially, and usually they do. And you run a 5th generation screening test that shows both P24 analyte and your antibody analytes. And then you follow that with a confirmatory HIV differentiation test and a viral load. And what you could do is ask your lab, even if you get a negative on everything, I'd like you to do a qualitative and a quantitative viral load as well. Some labs will say, no, we want to do the full algorithm. And then you say, fine, just make sure that whatever the results of your screen and your supplemental are on antibody, that you also do a qualitative and a quantitative viral load. And if this scenario persists and you still have a patient, like occasional patients that we confront, that continue to react non-specifically to our screening test, but without any confirmatory test, and this can, as we said, can go on for weeks, if not months, then we have to consider the patient's history. And sometimes patients' history will be about, eventually your pregnancy will end in a delivery. Eventually your flu or your mono will end. Eventually, I don't know about nowadays because we're constantly getting vaccinated against one thing or another, but eventually there'll be some brief period of time in which you haven't recently received a vaccination against COVID or flu or RSV or whatever. And that will give you a window during which you can test and hope that your tiebreaker will be a tiebreaker. If it isn't, and you're concerned and the patient is concerned, then we can take further steps to ensure that we have a laboratory that is somewhat more sophisticated or offers us a wider variety of testing and culture opportunities than we have by just checking off what we want from a commercial lab or the public health laboratory.
Yeah, right. And oftentimes we'll get asked, what's the adequate amount of time to repeat testing for this tiebreaker? What's your kind of recommendation?
It depends on the situation. And if, for example, you have a recent exposure and you know there really hasn't been enough time because the patient's history is good and there really hasn't been enough time to to generate antibody or even to see detectable virus or P24 antigen, you want to wait at least a week longer. But sometimes a patient will come to you and say, tell you about an exposure that he had over the weekend and want to test immediately. And that's when you have to say, if I test you right now, which I'm happy to, and I should, your test results are going to reflect your baseline, not what happened over the weekend, but whether you already have HIV and don't realize it. So you can test that patient, but you should wait at least 10 days after the exposure, if the patient's dates are accurate, to get a qualitative viral load, hoping that the eclipse period will be over, that period during which we can't find HIV in the plasma. And then the patient has had an opportunity to have circulating viral load, P24 antigen on day 12, and then antibodies starting to be safe, I would say, on about day 18. So wait at least a week, if not 10 days.
Okay, great. Thank you for that. Yeah, very helpful. We've talked in the past about patients living with HIV that over time may lose antibodies. In particular, I think you've shared some manuscripts about, those that are started very early in their HIV infection, started on antiretroviral therapy, have remained suppressed for long periods of time. There have been cases that we've gotten on the CEI line where patients are either transferring care to another clinic, or other times it's been a migrant from another country that has come and says they're HIV positive on antiretroviral therapies. And just as part of routine screening, HIV testing is done and that comes back as negative.
An increasingly common scenario, which we have created in a good way because we've got to them early enough or for a long period of time to the point where they don't have any circulating viral antigen. Their bodies are not being stimulated to produce antibody. And that is most common when you start somebody during the period of acute HIV infection, when your infection may still be concentrated in the mucosal surface where it originated, if it's a sexual transmission, and it may not have spilled over into the plasma and be detectable by us with our standard means. And yes, there is literature, and we can post some links to literature that have recommended to us that we need to be thinking further about HIV diagnostics when our plasma viral load is suppressed. We're not doing colonic biopsies or lymphoid tissue biopsies, and patient is switching care. And how do we confirm, which is the institution's protocol, that the patient has HIV if their viral load is undetectable and they don't have any circulating antibody? What do we do?
Yeah, no, that's a very excellent question. I wanted to ask, just in terms of more diagnostic tests for tiebreakers, what are your thoughts on, use of proviral DNA? So I think those archive assays and or Western blots as tiebreakers.
Yes, I love the Western blot because there's something that a laboratorian can sit down and look at. And we're not totally dependent on a machine. Machines are wonderful, and they allow us to do heavy throughput in a very short period of time. But looking at a Western blot, when you're trying to resolve the diagnosis, you're actually looking at concentration of color. And you're looking to line the glycoprotein molecular weight up with where the color band is. So some of us that are involved in resolving these ambiguous test results sincerely miss the Western blot. But you bring up something that I was about to say when we were talking about tiebreakers, and that is that if you have ever gotten infected by HIV, with HIV, your system will store what we call your system will archive proviral HIV DNA. And that will be that is a test that a specialty lab can do for you. Some of them are commercial labs, and the state health department at the Wadsworth Laboratory can do it for you. We don't offer proviral DNA testing at the New York City Department of Health, but we can describe the situation and get permission and a rec approved at the state health laboratory. Also, Monogram will do it for you.
Yeah, that's very useful information to know. So besides those tests, Lucia, are there any promising advancements in HIV testing technology that you're excited about? Or
as everybody who has HIV patients and does HIV work already knows, HIV never stops moving. And papers that were great like 3 years ago are totally obsolete now. And this has been the story of my own publication record, is that you break new ground and then somebody else breaks new ground and somebody else breaks new ground after that person. And this is a field that is always in a state of development. And one thing that is being tested and is in pretty common use from what I understand in the developing world is point of care RNA testing. So rapid RNA qualitative testing that has been helpful in the developing world after all the point of care antibody tests are second generation, so they don't pick up P24 antigen, and they also are of somewhat reduced sensitivity. But this point of care RNA testing is something that holds a lot of promise and has made the field of diagnostics do some complicated thinking about, do we want to move to a two-step algorithm where you go right from high sensitivity screening with P24 analyte directly to a nucleic acid test that detects HIV RNA? So that's kind of exciting. I am a big fan of multiple tests before you deliver a judgment, because I've seen so many false positives and seen so many mistimed tests that I'd like to see everything line up nicely. But there are times when it's important to do something in one day, because that's the only time that you have the patient. And that's especially important when you're taking the clinic to the patient instead of making the patient come to you, and which can be hard on the patient. So that these rapid diagnostics that are, as long as we validate them, that is something exciting that we have to look forward to.
Yeah, no, absolutely. And just finally here, would you say that just as a laboratory expert in the city, do you find that these ambiguous in test results are increasing, or what's some of your sense?
We have the challenge of PrEP, and we do, whether they're increasing, the results that we get, not directly from the laboratory, but from the state health department, which gets them reported by laboratories to ECLAIR system, the electronic clinical laboratory reporting system, they are all confirmed positives. How long it takes to get to that confirmation is something that we aren't seeing many more cases of ambiguous results than I can recall in the past. I think much of that is because our tests are getting better and better. And there's a lot of incentive in the laboratories and at the bench for improving tests. And whatever the incentive is, it also involves selling more of them and improving their instrumentation and their interpretation capacity. So I don't think, aside from the PrEP issues that we are going to face increasingly, especially with long-acting PrEP, and then that aside from that issue, we aren't seeing a big jump in ambiguous and discordant results. But if we're testing people early, like your scenario where we have a recent exposure and a person that is caught under the umbrella of timing is everything, and that includes bad timing, and you have a scenario in which somebody is coming to you 2 or 3 days after or longer after an exposure that person is worried about, you've either got to get them on PEP immediately if it's within 72 hours, or get that person to counsel patients and to wait for another 9 or 10 days so that you can find HIV RNA in their plasma.
Yeah.
There's a lot of waiting involved.
Yeah. And I think you've spoken to how to communicate this uncertainty with patients. Any final words on that?
I think it's worth telling patients, after all, they're there in your office because they trust you, or at your clinic, and they're concerned about the possibility that they might have HIV, which is good that they are concerned about it. They may be getting an STD test. They may come from a monkeypox vaccination, whatever the reason that you got them in the office, or that they were prompted to show up at one of our sexual health clinics. You've got them there, and you've got them past the first step, which is concern. And that it's something that they are concerned about, as they should be, if they know that they have exposures. The best thing is to take advantage of that, and then to tell them, however the test results come out, we have two things to offer you, and they're both really good. One is that we can put you on PrEP, and we can follow you over time. And PrEP is getting easier and easier to take. It's not a pill every day anymore. There is a flurry of research into whether you can do what we call on-demand PrEP, like you do some PrEP before you know you're going to have an exposure at a party or a bathhouse or whatever, and then PrEP right after, and then PrEP the next day. Or you can do your everyday PrEP, or you can do your injectable PrEP. And then if you have HIV, you can get on antiretroviral therapy that will bring your viral load right down and set you up for a long and good quality life and prevent you from the danger of transmitting to other people. Right. So whatever the situation is, we have two positive things to offer our patients. And I think that should give them heart and allow us to be positive and optimistic with them.
Oh, great. I am. That's like the same approach that I take. It's kind of that whole status neutral care. So if they are in fact negative, we can offer them prevention service. And if they are positive, then we can offer them treatment, and patients can live very long and healthy and, productive lives. So I like that optimism.
And and everybody who reads our epidemiology report knows that the primary causes of death in patients, and people are dying at older and older ages, just like the general population does, is heart disease and cancer, and non-HIV related cancers. Very few people are, and continuously diminishing, people are dying directly of their HIV infection. They are living out a full life just the way the general population of New York City does. And it's heart disease and cancer that are their prominent causes of death, just the way it is in the rest of the city and the United States as a whole. Well, so we got to get them on statins.
That's right. And that's another
conversation.
And that's another podcast.
Incredible clinical trial of statin versus placebo. It feels like we ought to be putting statins in the water.
Lucia, it's been great chatting with you. Thank you so much for your insights. They've really been invaluable. And just thank you for taking the time to really keep us up to date with how to really best interpret these ambiguous and discordant HIV test results. Thank you.
And Tony, thank you for having me. It is always a pleasure to talk to you. And you always ask me challenging questions that make me think. And I am very grateful for that and for the opportunity to have this conversation.
And I want to thank our audience for listening to this episode of Conversations with CEI. We encourage you to visit our website for more resources on HIV testing and prevention.
Thank you for tuning in. Join us next time for a new episode of Conversations with CEI. Visit us at ceitraining.org and follow us on CEI social media platforms.